Okay. So, Assalamu alaikum, everyone, and good morning, good afternoon, or good evening from depending on where you are joining, which time zone. So again, we are back with the yet another webinar in the series from the APPNA MERIT Healthcare Research and Innovation Landscape in Pakistan webinar series. And as the participants know very well, that we do it every 2 weeks. My name is Sarfraz Hasni. I'm a rheumatologist and the director of lupus clinical research at the National Institutes of Health in Bethesda, Maryland. And our panelists are Dr. Uzair, Dr. Sarodas, and Dr. Umar Hayat, as usual, and technical support by Waleed. It's our distinct pleasure to welcome today Dr. Namirah Jamshed. Dr. Jamshed is an associate professor in the Department of Internal Medicine and Family and Community Medicine at the UT Southwestern Medical Center in Texas. She also has a master's in healthcare policy, and she is a specialist in geriatric medicine and dementia, and a medical director of the UT Southwestern Care of the Vulnerable Elderly Home-Based Primary Care Program. She earned her degree from the Aga Khan University in Karachi, and after that she completed her family medicine residency in geriatrics and a fellowship at the University of California in Los Angeles. And she's certified by American Board of Family Medicine. And her academic interests include population health, health policy, and teaching. So she is very much involved in academic circles and with the American Academy of Home Care Medicine, American Geriatric Society, and the American Academy of Hospice and Palliative Care. So with that brief introduction, again, welcome Dr. Namirah Jamshed. Thank you so much for taking time, and please take it away.
Okay, thank you so much, Dr. Hasni. Assalamu alaikum, everyone. I just want to give a little background before we start the presentation. The topic of quality improvement emerged from our discussions with young physicians on the forum for our APPNA Young Physicians Committee. Some of you may or may not know me. I used to be a chair 3 years ago, and Dr. Naman Ashraf is our current chair. And it seems to be that quality improvement is maybe not something that everyone is aware of back home. This is a very initial introduction to that idea, and I hope that you guys take it away and want to learn more. And if you do that, just let us know, and we'll be happy to do that. So I'm going to share my screen. And let's see, where is here? Okay, so for those who may not know, quality improvement in the US is a huge deal now, and in North America, and in many other European countries. And we hope to bring this to Pakistan. At every level. It can be done in private practice, it can be done at an organizational level, but typically is a team approach, and you'll see how that works. So why is it important? Every thing we talk about should have a reason, right? It's important because healthcare systems, even in Pakistan or in the US, anywhere in the world, are very complex. A lot of times we're right at in the middle or the end of the system, and we don't understand what's going on in the top. And regardless of that complexity, our goal is always to provide the highest quality of care to patients and to improve their health. At the end of the day, whenever you're thinking of making a decision, all you have to think about is this good? Is this best for my patient? And if you think like that, then everything will start making sense. So that's simply what quality improvement is about. And it is really important. Now, we do know that if you participate in quality improvement, it can help you as a clinician and as a trainee to bring about improvement, not just for the organization or who you're doing the project for, but also for your personal skills. It does rely on collaborative work with colleagues and sometimes patients. And it uses a structured method. So it's not like, you decide one day and then you're going to go ahead and do it. And because it requires collaborative working, this is a great way of learning those skills as well. It does require enthusiasm, perseverance, and good project management skills. And we all learn by doing. So initially, maybe we're not the best at it, but as keep going on and keep doing this again and again, then you will start getting better at it. So what is it? What is quality improvement? There are multiple definitions. This is one of the simplest one I found, that it is about giving the people closest to the issue affecting care quality the time, permission, skills, and resources they need to solve them. So for example, if you hand over an operating room to an internist, they're not the ones who are the closest to the surgery work. It needs to be given to a surgeon or a or nurse, or whoever's managing the session. So the idea is that if I'm the one who's doing everything, I'm initiating it, I involve people who are around that issue that is affecting the system. It has to be systematic, it has to be well coordinated, and the approach is that you're trying to solve a problem using very specific methods and tools, and your goal is that you're going to bring about improvement that you can actually measure. We'll talk a little bit more about this to make it clear. These are some of the definitions that are used in the US. CDC says that it's continuous, it's ongoing, again, measurable improvement. You're looking at efficiency, effectiveness, accountability. US Department of Health, same thing, measurable improvement, continuous, systematic, and Agency for Healthcare, same thing. So you want to keep those things in your mind when you're thinking about quality improvement. Now, I don't know how many of the people here are trainees, but this is a very common question even for our trainees. What's the difference? What is the difference between research and quality improvement? And these are the main differences. The goal of research is actually to find or look for or test new knowledge. Quality improvement is more about best practices. It's an operating platform. How are you going to do something in the best way? In research, your protocol is static. You can't change the protocol while you're doing research, but in quality improvement, you can. It's very dynamic. You do a test, it doesn't work. Okay, we're going to do it this way. We're going to do it this way until you reach your goal. In research, you have to control for biases, but in quality improvement, you actually say that these are the biases and this is how we're going to stabilize them. The measures in research are unequivocal, which basically means that you're looking at very specific outcomes. In quality improvement, you might end up with things and it's a blend of outcomes as opposed to one specific one. And the data interpretation in research is always about, well, was this statistically significant or not? What is our threshold? And quality improvement, we're really looking for data trends. Research can answer a question. Quality improvement will meet a threshold for action. So for the purpose of people who actually have to go through IRB, you do not require IRB approval for quality improvement because your initial intention is to improve the system. It is not research. And because it's not research, let's say you did a project and it was very successful and you want to share that and publish it, you can do that without IRB approval. So there's history behind this. I love history. I read a lot of stuff and I enjoy it. And the history of quality improvement actually in the US and around the world started in 1939. It started with what we call the Plan, Do, Study, Act cycle, which I'll show you. And then in 1948, Toyota production system came up with quality improvement because of issues that they were having. Then in 1986, there was another type of quality improvement system called Six Sigma. And then 1988, the lean term was coined, and lean is actually a very popular term, way to do quality improvement now. But we're not going to talk about that today because it's at a very big organizational level. And then 96, we developed a model for improvement. Okay, today we're going to focus on 1939, the PDSA cycle. To Err is Human, Building a Safer Health System, 1999. If you haven't read this book, I would strongly recommend that you read this book. It was through the Institute of Medicine. It's very short, but since I live here and I can only talk about the data that we have here, but the reason this is important to know is that we have 44,000 to 98,000 people dying in American hospitals each year by errors that are actually preventable. And not only is the mortality, but also the issue of cost of 17 to 29 billion dollars per year. And you're spending this cost on care that was actually not safe. But as a human, it is very human of me if I make a mistake. So when we look at quality improvement, unlike what we may think of, we never blame a person or an individual or individuals. We try to find the fault with the system and the process that led to that error, and then we try to fix it, okay? So whenever you run into this at your institute, focus on the problem. Don't focus on the people, okay? And then it'll make much more sense. Sorry, we missed a slide. Okay, so people working in systems should deliver. So our goal as physicians is to deliver safe care, right? And we want to minimize what's wrong and we want to maximize what we can do right. We want it to be effective. You don't want to treat someone with an antibiotic if you know that it's a viral infection. It's not going to work, right? So you're not doing effective care. But for effective care, we need guidelines. We are very good in general, physicians, for delivering care with compassion and dignity and mutual respect. And then the care has to be responsive so that we focus on what matters to people. We focus on what matters to patients, what matters to their caregivers. And we don't decide what needs to be done. They are part of that decision. We are part of that team that makes the decision. So what does quality improvement involve? It involves, number one, you first want to identify a quality issue. So you identify an issue, and we're going to do an example of this, and then you try to understand the problem. But you understand the problem for a range of different perspectives. So think about it, that you draw a line, and then you say the outcome of the quality issue is that, say, the INR was too high, and it was not picked up. And then you go around the system, try to figure out who are the people or systems or processes that are involved in that result. So it's not one person. It is not one process. It's multiple things. Once you have figured out what the process is and you understand the perspective, then you're going to figure out what is the potential solution. What data do I need to test it? And then how am I going to keep refining it? Then you figure out the solution, you implement it, and then you keep going up and changing it. So when you identify the problem, it is a problem that you think is an opportunity to improve, okay? Or so you identify that, okay, if we did this like this, it would be better. And then you have to try to understand the situation, and then you have to describe the problem. So if you were going to take that problem to Dr. Uzair, you're not just going to say, sir, I want to organize the charts in this manner. He's going to be like, why? Why do you want to do that? You have to come up with, 1 minute elevator speech as to this is why I think we should do it. And then he has 1 to 2 minutes to listen to it, and then he has to go. So that is your opportunity. Then you're going to design the improvement, and then you're going to do data and measurement. So quality improvement cannot happen without team. And based on these data, you can have a 2-person group, which basically is very good for simple problems. You can have a 3-person group, and you can say, well, you know what, majority rules. So if 2 people become, together, then the 1 person loses. It's not a very good team to have. You should not have a team of 3. The ideal team, or the one that we think has the least tension, is a 5 to 9-person group, because you have less tension, you focus on problem solving, and you avoid deadlocks. larger groups are for information sharing, and then you know, depending on the quality improvement project, you may need executive sponsorship and other expertise. Okay, so I'm gonna, I do want to take a pause here and see if anyone has any burning question. We'll take one question if there is any. Okay, so we're gonna go on. So once you've identified your problem, remember we talked about it, that it has to be very specific and measurable. You need to create what we call a SMART goal. The SMART stands for the SMART, for specific, measurable, achievable, relevant, and time-bound. Specific means that the goal should be straightforward and it should state what you want to happen. I want the patient to be discharged within 24 hours once the discharge planning is started. Or I want the patient to be seen within 1 week of discharge if they were admitted with heart failure. Very, very specific, okay? Then the goal needs to be measurable. If you can't measure it, then you're not gonna be able to manage it. I want 70% of the patients who are admitted with heart failure to be seen within 2 weeks of discharge. So very, very concrete. And then the goal has to be achievable. It has to be within your capacity. If you're a medical student and that's not within your capacity, then the goal is not achievable. Then you need to find a team member who can help you. So it has to be a physician or a physician leadership. But also, if the goal is such that it requires too much of process change and significant changes, then it's not a SMART goal. It's not short enough and not achievable. And then it should be relevant. You don't want to start making goals for something that you're not the expert on, or you're not involved in, or you're not the one who's participating, okay? And the goal has to align with your organization. If the organization's goal is to see underserved patients, then your goal has to be related to that. It cannot be related to seeing, you know, patients who are privileged. And it has to be time bound. So you have to have a target. And typically, we want you to have short duration targets, but you know, you keep going on. So whenever we do a SMART goal, we ask you, when do you want to achieve it by? 6 months, 3 months, 1 year, and that's what you need to put in there. So here's a formula for how you achieve a SMART goal. You should have a verb, and then say from X to Y and by when. And then I put in an example. The SMART goal could be improving staff hand hygiene compliance. That's your verb on the medical surgical unit from 80% to 100%, which is your X to Y, and by when is within 3 months. So if we were to use the same formula on this other goal, which says we will increase the number of correct patient information form from 60% to 90% within 30 days in one PCP office. So what is the verb here? Can you all put that in the chat? What is the verb? What is the verb in this SMART goal? Anyone, just, so correct patient information is, that is sort of that is the measure. Okay, I'll take that. That's good. Anyone wants to take a thing of from X to Y? Okay, so increase patient information. Good, excellent. X to Y would be 60 to 90%. Very good, Salma. That's excellent. And then your when is 30 days. Good, Dr. Kamal. That's great. So hopefully you get the gist of this. So whenever you're doing a quality improvement project, you develop an action plan, you need to have a SMART goal. And it doesn't mean you need to have just one SMART goal, but that's where you want to start, okay? And someone's asking, can we do quality improvement individually? No. I mean, the whole point of quality improvement is that you have to do it as a team. Now, you may be the person doing a lot of the work, but you still need a team to work with. So we're now going to move on to how you achieve these SMART goals. You know, so we talked about 1939. This is one of the ways we do quality improvement. It is the most common way of quality improvement in at least the US healthcare system. And it is probably I don't want to say easier, but it is more doable than the other ones and can be done by a small team of 7 to 9 people, and sometimes even 3 people, yes. So you start with planning, right? You start with planning and you identify the problem, you analyze it, and you try to figure out what is the cause, okay? You create an intervention, and then you do, that means you implement the intervention. Then you're going to study the intervention that, okay, by putting this in place, this is what happened. And then if you feel that that intervention was a positive intervention, then you may implement it. If you think that it was not where you wanted to go, you go back to planning. And the reason there's a circle is PDSA cycles are continuous. There is no ending to this. Even if you feel like you've achieved your goal, you have to keep studying, because whenever that dip comes, you have to start with planning again. It is not a static cycle. So you just keep going, you keep going, and it doesn't mean you're going every week. Sometimes when you have achieved what you think is a good answer, you may keep that implementation for a couple of years, but you constantly collecting the data. So once your team is in place, decide how you're going to implement the intervention, who is going to do what. And this is where a lot of the times students and graduates come in, where they're the ones who are sort of like doing the scut work or, doing things like that. When are you going to do it? What are the things you're going to need? And if you use these questions, then it will help you organize your plan. The second is your do, like we said, and your do is once your plan is set in motion, you're going to implement it on a very small scale. And then, you're not looking at 2,000 patients even sometimes, like you're looking at 50 patients or 25 patients, and then you keep growing. And then you start collecting your data. Then you study your data. You see what are the results, you analyze it, you compare it to what your prediction was. If you thought that you were going to be able to enhance something by 75% and you've enhanced it by 80%, that's great. But if you did not enhance it by 75%, then you have to figure out what you need to do, okay? And then you use graphs and things like that to impress your mentor or your supervisor. That actually has 3 components. And this is something that I learned much later. When you decide on a plan and you implement it, you then have 3 options at the end. Once you have a result, are you going to adopt it? Did it work? Great. You're going to adopt it, you're going to hardwire it into the system, and then you're going to keep studying it. The other one is that you adapted, that actually it wasn't as perfect as you thought it would be. It needs some changes. So you're going to go back and start another PDSA cycle because it's an ongoing process. And the last is you abandon it. You abandon it because it showed no improvement or the outcomes were even worse. So it's okay to abandon a quality improvement project or a SMART goal, and that's absolutely fine. So in designing your next project, what will you do to ensure that you understand the problem you're trying to solve? So I want some people to answer this question. So let's say that you already know that there is a problem at the hospital, wherever you are, or in the clinic. What is the first step you're going to do? Let's see in the chat. Anyone? You're going to make a statement of the problem. You're going to survey. Vinesh, that's an excellent idea. Survey is can be a needs assessment survey. You try to figure out, validate the problem, good. Identify the problem. So you've already identified the problem, Dr. Afridi. Now what you're trying to figure out is the details of the problem. No, plan is too early, Dr. Hayat. You have to figure out, remember what I said, you have to figure out the root cause, the processes, what are the things that affect it? So for example, if there was a bad outcome, let's say this happens here in the US, now not as much, it used to, that a surgeon operated on the wrong leg, okay? And that sounds horrible, but it happens. Now, if the surgeon operated on the wrong leg, is it all the surgeon's fault? Right, it's not all the surgeon's fault. So who else is involved? Who else could have been involved in or could have helped the surgeon? Nurses, very good. Anesthetics, tech. Keep going. This is think beyond the operating room. Paramedics, okay. Vinesh, the question is, if a surgeon operates on the wrong leg, who all are involved? Administration, why would administration be involved? Maybe they don't have a good system of identification, right? No, junior doctors are not responsible. Remember, we decided we're going to focus on the problem. Working environment, very good. All right, let's go to the next question. Now you've identified, Dr. Siddiqui, of course, sounds like you know exactly what to do, the fishbone diagram. And I was going to do it, but then I thought it might be too much information. But basically what Dr. Adnan Siddiq is saying is you create a fishbone, and then at the head of the fish is the problem. And then the bones of the fish are the people, the processes that are involved in this. So how will you involve your colleagues and patients for this project? How will you try to get support? You can call a meeting if you're in a leadership position. Bring it up to a senior doctor. That's good as an idea. Yeah, that's very good. Identify address. If you're really, really passionate about it, you need to identify one person in the very senior level who will support you. And then you start identifying other people and creating a team like that. But yes, everybody has had the right answers. And then let's go to the next one. Okay. I want people to write a SMART goal on the chat for a problem that they have seen or experienced in their work. So go ahead. So we are going to write a SMART goal for a problem that you have identified in your area. Anyone wants to create a SMART goal? I can't believe that nobody has, people have not had problems or things that they noticed are happening. Get staff, get COVID vaccine from 60 to 80% in 3 months. Okay, good. Reduce the patient waiting time 2 hours to 2 hours from what? Dr. Amjad, you have to go from X to Y, remember? And then all of you are missing the when. Everybody has the verb and the X and Y, but there's no time bound. Reduce wrong prescriptions by 20% in the next 2 weeks. 20% from what? Or I guess maybe you may have a baseline to decrease polypharmacy in PCP within 30 days from 7+ to 4. Very good. That's very good. So everybody seems to have an idea. Good. Reduce number of needle sticks injuries to less than 15% in 6 months. Okay, and then you do want to say, if you only have one number, you want to say less than 15% from. So it really, and this is where the homework comes, right? You don't write your SMART goal just because. You actually have to do your homework of what is the baseline and where do you want it to be, okay? And sometimes you don't know the baseline, then you can start collecting it. And I think that's absolutely okay. So ideally X to Z, if you don't have both the numbers, you may say that I'm going to use this as my baseline. And then when we implement, we'll look at, the 10% changes. All right, great. So we are going to spend the next 10 minutes and then we'll open to questions after that on a case. And I wish people could speak, but I think chat is fine as well. Dr. Hasni, whatever you prefer. So this is a case, and let's say you're in a primary care clinic with a resident, okay? Outpatient resident primary clinic, the resident sees patient 1 in exam room. The medical assistant or nurse knocks on the door and tells the resident that patient number 2 has arrived in the room next door. And then the resident who has looked at the list of patients scheduled for today and knows that there's a 29-year-old man with alcohol, HOH cirrhosis is next on her schedule, requests that she would like, or he would like, or they would like hepatitis A vaccine while the patient is waiting. So the medical assistant or the nurse confirms that the vaccine will be given to the patient next door, and then they leave. All right. What do you think happened? 10 minutes later, the resident goes to see the patient next door, but the patient next door is actually patient number 3, not patient number 2. And this patient number 3 is a 43-year-old person, Portuguese-speaking male in the room, and gets the vaccine. So upon discussion with the medical assistant confirms that it's patient number 3 who got the Hep A vaccine instead of patient number 2. Now, patient number 2 was in a different room, while patient number 3 was scheduled for a different resident. So I want to raise of hands of any one of you who has known of or seen a wrong medication or vaccine given to the wrong patient when you ordered it for the one person. I know we don't, it's anyone. If you have it, you have, okay, all right. Dr. Kamal, you want to tell us what it was? Was it a medication or was it a vaccine?
So I'm not sure if
they can they type?
Participant, maybe they can type in the chat, but
yeah, okay, that's
the
fine.
audio is not.
No worries.
Yeah.
No problem. Okay, let's go to the question. So APPNA MERIT has very kindly provided a poll for me. So let's start with the first. So everybody understands the case. You went to see a patient, there was a second patient, and then the third patient shows up. You order Hep A vaccine for the patient who has alcoholic cirrhosis, and the hepatitis A vaccine is given to another person, okay? What is the first thing you're gonna do if you're the physician? Before I ask you any poll questions. Think of yourself, if you were the patient and you got confessed to the patient, okay? Check on patient 3, patient 3 is fine. Oh, Dr. Salma, I'm sorry to hear that, but hopefully everything was okay. Tell the patient, confess. So it's not really a confession, Dr. Aslam, but yes, you have to tell the patient. The first thing you must do is be honest, okay? You tell them that a mistake was made and an error was made and that it will be addressed, but and then you go through that. All right, let's go through the poll question, all right? The first question, have you ever experienced a mix-up or error in patient identification or treatment at your healthcare facility? Wait for the poll and question, and then I want everyone to answer. Can we have the poll question?
I think, yeah, here it is.
There we go, thank you. Oh, they're all coming in together, no worries. So the first question is, have you experienced it? Please say yes or no. The second question is, how frequently do you encounter situations where patients with similar names or conditions are scheduled consecutively? And the third is actually, should be, is incomplete, but that's okay. So can we answer the first 2 questions, please? And let's see what the result is.
They can roll down and these subsequent questions will be visible.
Oh, I see. I see. So go ahead and answer all these questions. Question number 3 is, in your opinion, what could be the primary contribution factor for the mix-up? Is it because there was lack of communication? So all those who are attending, you need to answer on this poll. You have to click on this circle. If you click on it, that will be your answer.
Do you want me to roll up again, or Did everybody got the first?
No, I think we're okay. I think that it's, I don't know if poll questions have been done before, but I can't vote, but if I was to vote, like if I was to say, yes, this is where you want to click. So let's give everybody 1 minute to do that. Are we getting any numbers in?
No. Walid, are you seeing numbers at your end? Polls or?
Yes, we are getting.
Okay.
I
Good,
will share the
good.
result in a minute.
No,
Okay.
that's fine. Thank you very much. We'll just wait for the results.
So I'm just gonna, I have scrolled down to number 5 and 6, then I can scroll down further
Okay.
to 7 and 8.
Okay, I think we can close the poll now. So we can spend 15 minutes on. Thank you. All right, so have you ever experienced a mix-up? So 70% of you have, which makes sense, and 30% not. But this is not uncommon in any healthcare system, and that can happen. How frequently do you encounter situations where patients with similar names or conditions are scheduled consecutively? Pretty occasionally. It's a tough situation. You know, many of us have the same last name. In the US, everything is about the last name. In the West and Europe and Pakistan, it's mostly first name. And you know, if you have similar names and you're not looking at the date of birth, it's really hard. And here, because we have electronic systems, things are flagged. But even then, I know of 2 occasions this year where the message was taken by the person for a patient and was put in the other patient's chart and a different patient's chart. In your opinion, what could be the primary contributing factor to the mix-up? Lack of communication. So let's talk about this. It seems like the resident and the nurse did talk to each other. So inadequate patient identification. There's no right answer here, by the way. I think all 3 of them are there. It is a human error, but it's all, mainly a lot of this has to do with the patient identification protocols not being in place, because this is something you could simply fix with a checklist, right? Name, date of birth, this, that, and then you know, and then give the vaccine. And if you're ever in doubt, of course, ask. What measures or protocols do you think could have prevented this? Everybody had different answers. And like I said, honestly, there's no right answer here. Improved patient identification would help, clearer communication would help, and double checking would help. So now you see, you're starting to identify the problem, that this problem is actually does not have one root cause. All 3 of them are the cause. And the mandatory language proficiency actually is also a possibility, right? It's a Portuguese speaking patient. They can't answer. You actually needed to have a language translator or someone who should have asked and verified that information from them. How concerned are you about the potential consequence of patients' misidentification in a healthcare setting? Very concerned, somewhat concerned. You should all be very, very concerned, okay? Because this may be a hepatitis A vaccine that, you know, hopefully nothing bad happened, but patient could have had a serious allergic reaction and died. And if you don't think of it as a very concerned issue, then you may not have a low threshold for change. Have you received specific training? So no, but I would like to. So this is a great opportunity for APPNA MERIT, that this may be a great topic for training or education in how to identify patient protocols and procedures. And you can do that. And do you think technology such as EHR will help? It does help, and it has really shown to improve preventing errors, but it has not made them zero. So the it is reliable, but it's not the only answer. You still need other systems in place. What steps do you believe should be taken to prevent similar incidents? Most of you wanted to enhance communication and teamwork. honestly, that's a great idea, but it wouldn't be the full answer. The residents seem to have communicated well with the MA or the nurse, and despite that, it happened because the stricter patient identification protocols were not there, because they don't do regular audits and assessments, and because they may not have invested. So all of these answers are actually needed. So I am going to end here. I appreciate everybody's patience in listening to me. I hope you found it useful, and I hope you leave excited and start creating SMART goals and trying to figure out how you would do your next quality improvement project. Very simple one, and it'll work for you. Thank you.
Thank you. So, Dr. Jamshed, that was an excellent presentation on
Thank you very much.
quality improvement. So I'll open it up for our panelists, Dr. Zair, Dr. Sarwat Hussain is here, Dr. Umar Hayat, for their comments. And I know I think that
again, as you said, Assalamu alaikum. As you said, that excellent presentation. This really was very, very good presentation. And I think I learned a lot, and everybody learned a lot. But let me share some thoughts on it. So back in 2017, first of all, I'm very interested in quality improvement. When it started in the early 90s in America as a part of legislation, it was my responsibility at Boston University and later on at University of Massachusetts to lead the quality improvement in the Department of Radiology. Having been kind of motivated by that, I started a company or a group called and registered in Pakistan called Healthcare Quality Institute, and started providing quality improvement services to the hospital, and including May Hospital Emergency Department. But the problems on ground in Pakistan are vastly different than what they are in the United States. And in Pakistan, it is very, very difficult to implement quality improvement for several reasons. And it's not a discouraging story, but something to learn from and build upon. So I started the company, hired 2 doctors and 1 administrator, paid for my pocket. I made 8 trips to Pakistan in 2018 to try and establish this company. And wherever we went, everybody said that, can you do us a free project? And then we will talk about the results, and then, we can start some monetary payment to the staff that we have. Obviously, nothing is free in this world. So we did do the projects, and I spent $200,000 of my own money in order to make this work. But everybody wants free project. Nobody made any payment at all for the work, at least the cost, not even the cost. The problem in Pakistan is, number one, people obviously have no concept of quality, or not. I'm sorry, it's not the no concept, but people have concept of quality, but it's difficult to implement because there is a competition of time and resources between private practice and the hospital work, especially the free work and the time that quality improvement requires in the institution. And unless that is funded by the institution or the government, nobody will have time from the normal daily work and the evening practice. Secondly, the number of patients are in hundreds in outpatient, and in absence of staff, the quality improvement is very difficult to do. And thirdly, the leadership, quality improvement is a top-down thing where the leaders have to be committed to quality improvement and be personally involved in this, so that people underneath are going to implement that vision. And and the other thing is that the results of quality improvements are not immediately evident, and there is lot of, if you will, redundancy of resources before the results can be made available. And then there are culture of not admitting faults in our society, where the teacher will never tell you that I made a mistake, and they will try to hide and blame on the others, as opposed to what Dr. Saiba has said, a very illuminating talk. The first thing that we do, and let me tell you my personal story. I was doing a biopsy of a patient in the pelvis, and the patient kind of first supine, then prone, then supine, then side, et cetera, et cetera. In any case, we did a biopsy on the wrong side. And the first thing we did, or we had to do, very important indeed in this society, is immediately do not hide your mistakes and tell all the stakeholders that you have made a mistake. And the mistake actually occurred because at the time of the identification of the patient, and when we started the wrong side of the biopsy, the nurses, although knew about it, did not speak up. And there is a clause in the quality improvement that anybody, any part of the team member can call what is called a hard stop. Any member, even the technologist, can say hard stop means that you stop everything and reevaluate the situation as to whether the wrong, anything wrong is being done. So these are some of my comments. These are not discouraging comments, but these indicate that the scenario between the Western world and the Eastern world in Pakistan is different. And I have to say that Aga Khan Hospital really kind of sits between Western and the Eastern world, and it has all the good things of the Western world and some of the not so good things of the Eastern world. Therefore, you can implement quality improvement, and especially when there is no evening clinic that compete with the regular work. So with that, I'm going to stop and forward the discussion. Thank you very much.
Thank you very much, Professor Sarwat, and thank you very much, Dr. Jamshed. What a wonderful talk. And when we discuss about the quality as the dimension of management. So it's more so it's a regular, proper, coordinated process. Allow me now, they have increased this mantra of smart goal to smart cow. They have added 3 more. The cow, the C stands for consistent with the long-term objective, and O, observable, that you see the things are actually happening. And the most important thing in any quality is W, written, because if it's not written, it does not exist, because you can't change it unless it's written. So whatever you may be having in your mind, the ISO standard and the quality standard, the first thing first is right. We have with us Umar Hayat, the most stringent quality assurance is in pharmaceutical, the GMP, current good manufacturing practices, because there's no such thing like GMP only, which means the good manufacturing practice. That small c, current, make the difference. It should be current as of today. So, and these ideas, so in the quality, Six Sigma, all those things, they are very fast going up, and they are applicable to all the sciences and whatever we are doing. So it was a great talk. And the first thing that's the more interesting and compliment to Dr. Jamshed, that while discussing, she replied to all the questions. So what a smart approach. She is absolutely in control of everything. So she has a full control of management. So she is following the smart cow criteria into everything, like the time management, the response time, the reactivity, so everything. And she planned, that cycle, plan, do, act, because she planned and everything was timely synchronized. So when you learn these principles, in addition to your professional life, they are going to affect each and every aspect of your life, personal life, whatever you do, because now you realize that how the planning is so important. And it's always a learning. Even very, very simple exercise. Even if you're shaving, count down the steps, and the next time you can always improve. And this is $1 million activity, because in pharmaceutical, if you bypass a couple of steps, you can save millions of dollars, because you can simplify the procedure. And unless and until you observe it, you can't learn it. You need to have a very observant eye. Umar, would you like to comment about these things? How important, these documentation is in healthcare industry, particularly the pharmaceutical, all FDA audit. They start first with the documentation, and then they go and visit. If it's written, if it exists, and they are doing it, so the chances of elimination start from having a very stringent criteria, that SOP, like IATA pilots, the pilots, they are flying the same plane for the last 30 years. But they have to, once again, it's written, it's in front of them, and they do 1, 2, 3, 4, 5. So would you like to comment, Umar, please?
Thank you very much, Dr. Azad. And thanks a lot, Dr. Jamshed. It was a quality presentation, by the way, and you engaged the audience very well. And quality, I mean, is a mindset. And it goes from industry to industry. You mentioned the Six Sigma, and Toyota was the one who started, and that's how it took off to the other sectors as well. And I will say the time comes where you need to link the quality slogan to the efficiencies and the cost, and that's which attracts everybody's mind, including the management. To the point what Dr. Azar was making, pharmaceutical, I mean, you make a batch and there must be probably millions of the tablets. So if any error is made, it's not a one person going to be affected. It's going to affect the millions of the people. And even in terms of the cost, having the recall, it costs probably even more than the manufacturing cost. So there is a everything at stake, I will say. Very true, as Dr. Azar said. We believe if it's not documented, it's not done. Okay, so that's a simple rule in the world of the pharmaceutical. The other thing is when we talk about the current GMP, it's evolving. As I said, it's a mindset. I mean, in terms of the Pakistan, not want to be the negative. We believe everything is good. Okay, and that's not very often true, especially if you believe in the continuous improvement, because there is no limit. Sky is the limit when you talk about the continuous improvement, and that's where the word of current good manufacturing practices come. The other point I would like to make is the details. I mean, how much. So I use this slogan very often. We call it the master batch record when we put the instructions for the manufacturing of any drug. So we say, I mean, I say normally, the batch record should be written in a way that shoemaker can make it. So yes, the knowledge has been developed, and now you put into the practice or in the written document that anybody should be able to follow. I mean, shoemaker, I use the example because he is not basically trained for that, but the instructions are such that shoemaker can make it. But thank you very much. I think it was a wonderful presentation. A lot of learning. I mean, we practice whatever the profession we have, but quality is something, and I will say the continuous improvement, and the sky is the limit for that. Thank you very much.
Thank you. Thank you so much for the panelists for their comments. I think we have a couple of minutes left. So Dr. Jamshed, if you have any parting comments, or if you want to expand on questions.
I want to add to something what Dr. Uzair said. So, and Dr. Umar as well. You'll be surprised that even in Pakistan, there are still multiple organizations. My father was in the airlines that actually do have quality improvement, but they're not healthcare, right? And somehow in healthcare, including here in the West, this is not about Pakistan, this is everyone. We just think as physicians, we can do no wrong, right? We make a mistake, but no, it wasn't, it was we feel like we work so hard, and we shouldn't have to answer, and we should be able to do these. I think that mindset is changing. I know it's taken a long time, even in the West, and that mindset needs to change in Pakistan. And I know someone said in the thread that in Pakistan, there's no compelling reason. You are the compelling reason, right? The fact that you're attending this session is the reason that we should bring about change, and you are going to bring about change. So if a student has an idea, even one faculty supports it, and like everybody said, and you publish it, it's going to go other places, right? We didn't have Indus before. We didn't have AQ. We didn't have Shiv. I mean, I know a few hospitals. I know there are many others. I apologize if I'm not saying that. But you'll be surprised that AQ did not have a focus on quality assurance until a few years ago, as in an actual support. They were doing it, but you need the health system. The other thing, I do agree with Dr. Hussain that it is hard maybe in Pakistan, but I really believe in making small changes and starting small. If you start and mashallah, he was at a very big and a very different level, but you can do these. This is why I only talked about BDSA today. You can do this at a very small scale and bring about such a big change for your patients. Okay, so please believe that, and I hope we can change the narrative. Thank you.
So on a very positive note, thank you again, Dr. Jamshed, for your time and for sharing your expertise with the
My pleasure.
audience. I would say that, yeah, thank you. And of course, thanks to our panelists, and technical support by Waleed is always excellent. And I think I would say that in terms of participation of attendees, it's probably one of the most interactive and one of the highest participant that we have so far, right?
Thank you.
All righty, good. So thank you again, everyone, and we'll come back with another series of webinar in another 2 weeks. And please watch out for that, and we'll meet again in 2 weeks, same place, same time. Until then, please take care, and Khuda Hafiz and Assalamu Alaikum.
Bye.
All the best.